My name is Terry King. I'm the Chief of the Division of Breast Surgery at Brigham and Women's Hospital and Dana-Farber Cancer Center in Boston, Massachusetts. So the ACOSOG Z0011 trial was a landmark study led by Armando Giuliano, asking the question, does all microscopic disease in the axillary lymph nodes need to be removed with surgery? The trial enrolled women with clinical T1, T2, clinical N0 breast cancer, planning to undergo breast conservation therapy with whole breast radiotherapy into a randomization to completion axillary node dissection or no further axillary management. Women were taken to the operating room, had the sentinel lymph node biopsy procedure performed. Frozen section analysis was done on the sentinel lymph node, on the sentinel lymph nodes, and women who were found to have 1 or 2 positive sentinel nodes were then randomized intraoperatively to completion axillary node dissection or no further axillary surgery. An exclusion criteria for the study was women found to have matted nodes or gross extracapsular extension intraoperatively were not eligible for randomization, and women who had 3 or more positive sentinel lymph nodes intraoperatively were also not eligible for randomization. Finally, again, women had to be undergoing planned breast conservation therapy with a plan for whole breast radiotherapy. And in the design of the trial, the intent was not to treat the axilla with radiation, but to truly examine the outcomes of women who had standard of care completion axillary node dissection in the setting of 1 to 2 positive nodes versus observation only of the axilla. It was quite a controversial study when first rolled out, and in fact, many large cancer centers didn't participate because they did not believe that it was could potentially be safe to not dissect the axilla in the setting of positive nodes. That had always been the mainstay of axillary management, and there was some concern that these women would experience high rates of local regional failure. Nonetheless, Dr. Giuliano and the investigators through the American College of Surgeons Oncology group, which no longer exists today and has now been replaced by the Alliance the Alliance for Clinical Trials, but the investigators persisted, and they did manage to enroll just under 1,000 patients to the Z0011 study. The study was ended early because, again, slow accrual, but on analysis of the enrolled patients and the events, the investigators chose to go ahead and do the analysis and present the data. When the data were presented, it was really game-changing for the local management of breast cancer, because the data did in fact show that whether you performed an axillary lymph node dissection or not, that women with, again, clinical T1, T2, N0 breast cancer undergoing whole breast radiotherapy, both women in both groups had very low rates of axillary failure at 5 years, in fact, less than 1%, and there was no difference in disease-free or overall survival. There was a lot of criticism that the study enrolled low-risk women, primarily postmenopausal ER-positive patients who primarily had micromets in their lymph nodes. But the investigators remained persistent, continued to analyze the data, demonstrating that there was really not a subset that was found to have a higher risk of a high nodal disease burden or a higher risk of local regional failure. What the study did demonstrate is that in women in the axillary lymph node dissection arm, 27% of them actually did have additional disease identified. And so one would argue that the women in the no axillary dissection arm also likely had a similar amount of residual disease that went undissected. And again, this did not result in higher local regional failure in the women, not only at the early reporting period at 5 years, but also at the second reporting period at 10 years, there was, again, still no difference in local regional failure by the performance of an axillary node dissection, and no difference in disease-free or overall survival. So I do apply Z0011 criteria quite freely in my population. Again, those for any woman with a clinical T1, T2, N0 breast cancer, planning breast conservation therapy, followed by whole breast radiotherapy. We do sentinel lymph node biopsy. We do not evaluate the sentinel lymph nodes intraoperatively because we are not going to dissect if there's only 1 or 2 positive nodes. And we know from other work led by the Memorial Group that in this population, again, the majority of patients, about 85%, only have 1 or 2 positive nodes. So we, again, do not evaluate the nodes intraoperatively. We wait for our final pathology. And in women that end up having 3 or more, we do go back to the operating room. In those with 1 or 2, we routinely do not go back to the operating room. The question of microscopic extranodal extension has been a point of discussion over in the early years after Z11 was presented, but it's important to remember that Z11 did not include any analysis of microscopic extranodal extension. Z11 did exclude women with gross macroscopic extension intraoperatively, but there was no collection of data around microscopic extranodal extension. The challenge with microscopic extranodal extension is that until recently, there really wasn't a clearly defined or standard way that pathologists would report this. Some pathologists would report any microscopic extranodal extension. Others would categorize it as greater than 2 millimeters or less than 2 millimeters. And although in the older literature, when axillary lymph node dissection was performed on all patients, the presence of this microscopic extranodal extension did seem to associate with higher nodal disease burden, there really was no evidence that that was true in the era of sentinel lymph node biopsy. The investigators at Memorial Sloan Kettering Cancer Center actually looked back at their experience with the presence of microscopic extranodal extension and did find that microscopic extranodal extension greater than 2 millimeters was associated with a higher nodal disease burden in the axilla. However, this did not translate into higher rates of local regional failure in women treated according to the Z11 criteria. So I am not concerned about the presence of microscopic extranodal extension in my patients that, again, meet Z11 criteria when I'm performing sentinel lymph node biopsy. In a woman who has 2 positive nodes, I am comfortable omitting axillary node dissection. If she has 2 positive nodes plus microscopic extranodal extension, I may review that case, again, with my pathologist, trying to understand exactly how much extranodal extension there is. I also want to consider the underlying biology of the tumor. Is this a high-risk subtype where she's going to receive chemotherapy? Is this a low-risk subtype where she may not receive chemotherapy? Is this a young patient who already has a higher risk of recurrence? So I want to consider all of the factors, but in the majority of cases, I am comfortable with 2 positive nodes and microscopic extranodal extension. I'm comfortable omitting lymph node dissection, again, in those women who would have met eligibility criteria for the Z11 study.